Excited to bring you a very cool episode. But before I do that, I have to remind everybody to join NAMI Tennessee's email list. Just go to namitn.org. It is absolutely free, and you find out about all of the cool things that NAMI Tennessee is doing. Things like, well, the NAMI Tennessee at-home live series, the NAMI walks, the NAMI gala. But here is really the most important thing. We send out legislative advocacy alerts, and those are things that you can do to help influence Tennessee's laws and the legislators to know the things that are important to the mental health community. And all of those updates are absolutely free, and they come out in the email list that you can sign up for. I know I feel like I say this every time. So please head over to namitn.org and sign up for that now. Again, it is absolutely free. All right, enough of that. We have a great guest this week. Ben, can you introduce yourself?
I'm happy to. My name is Ben Harrington. I am the CEO of the Mental Health Association of East Tennessee, and I've been in that role since 1994.
1994. I hate to say this because I hate it when people say it to me, but I graduated high school in 1996. So
Yeah.
you have been doing this longer than I have been a high school graduate. What have you, this was not scripted, I swear,
Yeah.
but what have you seen in mental health advocacy from 1994 to 2022? Because you've really been in a position to see a lot of change.
Well, yeah, some of the big changes have been things like the average length of stay at a state hospital in 1994 for a person with schizophrenia was like 22 or 3 days. And now that length of stay is about 5 days, maybe 6 days. And so the big change there has been advances in treatment options and medications, and that changed things in a big way. And then, of course, you had the advent of TennCare and the evolution of certain services within TennCare. Those are huge changes that we've experienced the whole way since 1994. The other thing I think is important to note is the advent of the internet, so we can actually do a lot of things like this cool program. But with the internet, we can also provide yeah, that was a shameless plug.
I love it,
But
though. I love it.
we can also do things like free mental health screenings online and let people anywhere they are in the state of Tennessee, identify their mental health treatment need, from the anonymous location of their couch at home or their kitchen table or, sitting in their car on their telephone. They can take a screen. So lots of things have changed, and some change has been very, very positive, of course.
Wonderful. I love pointing that out because it's very easy as a mental health advocate to get in this idea that nothing is improving, nothing is changing. But
Mm.
when you look at it, I mean, we have a long way to go. I don't want anybody to hear, "Hey, Ben said it's solved. It's better than 94." No, we have a long way to go. But
Yeah.
I do think it's important to consider where we've been and celebrate the success that we've had while being mindful of the success that we still need to achieve. So thanks for giving us that little snapshot,
Yeah.
Ben.
Well, it's always important for us to take a look at what we've done, and is there anything we can do the next time we're going to do it to do it better. And so that's about everything, whether it's an MHA project or event or a NAMI event, that sort of thing.
Wonderful, Ben. Thank you so much. Okay, my next question is, oh, whoops, I hit the wrong button there. Let's talk about your organization, the Mental Health Association of East Tennessee. Can you give us the big overview? I know you said that you've
Yeah.
been in charge since 1994. What are you tasked with? What do you do? What are the goals?
Well, we were founded in 1948, so we're going to have our 75th anniversary next year. And our organization really focuses on mental health awareness, advocacy, and some client services that we provide. And so we do a lot of early intervention in schools with a program called Mental Health 101, which is service marked. We created it, trademarked it, and we provide early intervention for Tennessee youth and middle and high schools. So that's a big deal. But we also provide the free screening program that I mentioned and screen about 16,000 people a year there. And then one of the other important programs that we operate is called the Peer Recovery Call Center. And sometimes people call it a warm line, but I think it's a warm line on steroids, if you will.
I love that. Now, oh, excuse me. Let's dive right into what a warm line is, because that's a term that not everyone has heard.
Yeah, so a lot of organizations have a call center type operation where they expect people from the general public to call and ask questions about where can I find help for treatment of diabetes or heart disease, that sort of thing. The same is true with the mental health organizations. Now, a warm line is a line where someone can call and they can ask all those questions, but they can also just talk with the person that they've got on the telephone about any of the issues that they're experiencing. So that's a different thing from someone calling, the front desk at a local hospital. But so what makes our line different is our peer recovery call center, our warm line, if you will, is staffed by persons with lived experience and in recovery from their mental health condition. And so they certainly understand what their callers are experiencing and struggling with and troubled by, because they've already been there. And so what they try to do is triage each call, Gabe, and identify what that person needs, and then finds them the right resources that will support that need. And that's extremely important. But then after that, we're not done with that client. That's what used to happen 20 years ago when people called an organization. They were given the information and no one knew what happened afterwards.
Right.
What happens afterwards with the peer recovery call center is we are going to make sure we get permission to call that client back. And that's extremely important from a quality control issue, so we can make sure the resources we're providing that individual work for them. But we also want to follow up to make sure they're doing okay. And then, lots of follow-up contacts happen beyond that. We average, Gabe, about 60 to 65 contacts per year with each client we serve. And so that amounts to about 24,000 contacts when you think about phone,
Wow.
emails, Facebook communications, texting, everything. And so the beauty of it is it changes the outcome for that person. All right. And so nationally, most people who need mental health care, only about 35% of them enter and stay engaged in treatment. And they don't have a peer support specialist involved there. But at the call center, it's 75% of people enter and stay engaged in treatment. And the secret sauce is they've got peer support, being their life coach, helping them make sure they are prepared for their next appointment, and they are their lifeline to keep talking with that person, in between every time they have a mental health appointment. So it is kind of the unique strategy that makes our warm line, or peer recovery call center, as we call it, successful.
I have just, there's so many directions that I want to go into with this, and it opens up a lot. But I'm trying to decide which one I asked first, 'cause I think they're both like super important. Let's ask this one first. A lot of people are familiar with 988. 988 has made the news a lot. And even before 988, of course, we were familiar with the National Suicide Hotline. How is this different from the 988 offering and the previous National Suicide Hotline offering that people have been aware about for years?
Well, it's the exact opposite. 988 and other suicide lines before it are designed to be the place you call when you are in a suicidal crisis. And then the suicide counselors can try to dial things down for you. So yes, we will serve someone who calls us and they're in a crisis situation, but that's not the majority of our calls. The majority of our callers are not at that level, but our work is to serve them so that we can help them get the right level of services that they need and enter those services and stay engaged. And we're going to provide that ongoing support beyond that first call. 988 is not going to be your constant lifeline to call, when you're not in a suicidal crisis. And so that's the difference there. Our call center can be a place for Tennesseans to call, and it's not a non-crisis call, but they have someone that can help support their needs, that can listen to their issues, can help them reframe really their thinking about issues, that sort of thing, because all the staff has been through all the RAP type classes. There, 2 are nationally certified peer specialists, 2 are working towards that certification, and all 4 of our team are Tennessee certified peer recovery specialists.
And that really leads, you've answered it a little bit, but I'd like you to expand on that. That was my second question. When someone calls, who do they get? Who's the staffing? What training do they have? How do we know it's safe? Who are they talking to on the other end of that line?
Yeah. So the first thing they get is someone with a welcoming voice and who understands exactly what they are experiencing. There's no scenario that's going to stun our team, because they're all folks with lived experience, and each are in long-term recovery from their behavioral health condition, and they're engaged in treatment still to this day and managing things very well and independent, and doing what we would expect folks could do, because we know the illnesses are real, diagnosable, and treatable, and treatment works. So now we're proving it every day with every caller, because they're getting someone that's living and breathing that expectation that treatment works and you can and do recover.
The next question that I have, I don't want to sound like a floating head. The next question that I have is, what's the phone number? If people are sitting here thinking, man, I need to call.
Yeah.
How do they connect?
So I'm going to give you 2 phone numbers, actually, because we're complicated. In the East Tennessee area, that phone number is 865-584-9125. Now, we do get folks outside of East Tennessee who also contact us. So if you're in Middle Tennessee or West Tennessee or Southeast or even up by the Virginia border, that number is 877-642-3866.
3866. And I imagine that the second one is the toll-free number, or are they both toll-free?
It's a toll-free. The local is also a free call, because the 865 is a local call, so it's also a freebie. But the 877 number is toll-free, so that folks from across the state can call us. Now, Gabe, the one thing I do want to make sure folks understand is this service is available to Tennesseans, and the majority of people we serve, it's about 96% are Tennessee residents. There are some folks that are outside of Tennessee who we continue to serve, and that is because it's their intent to relocate to the state of Tennessee, or they are a family member out of state and they're trying to understand Tennessee resources and get those set up for their loved one here in the state.
But primarily, it's the resources that you have and the information that you have is very specific for Tennessee. So if somebody was listening outside of Tennessee, it would behoove them to Google whatever their state is, warm line. So California warm line, Ohio warm line, Pennsylvania warm line, to find resources and a warm line in their particular region.
Yeah, that's exactly right, because there are warm lines in a number of places all across the country. I will tell you that it's important for them to ask a question if the warm line staff where they call in other locations are the people that staff the warm line, do they have lived experience? I think that's incredibly important. And I know in places like Minnesota and New Jersey, a lot of those call centers and warm lines do staff with people with lived experience.
And it sounds like your warm line is staffed with people with lived experience.
Oh yeah. From the get go, we actually looked at changing what was called information and referral. That's the old timey name for. Uh, you could call and find out. Well, I need to see a doctor for depression. Who do I go to? And we hand out a name and a phone number. So we looked at changing this years ago, and we realized if we were going to change this and operate a bigger call center operation, that we needed to get serious about employing peers, because Gabe, we called around and checked on a number of other call centers across the country that were supposedly very, very good, and they engaged peers as call center workers, but they didn't employ them. And so that really, you know, resonated wrongly with me. You don't say someone's good enough to be a volunteer and do the work, but oh, by the way, we're not going to pay you. That just plain stinks. So we wanted to set up the program and hire folks that would be peers, be certified peers, to be able to assist people most appropriately. And so we set up that model and raised the money to do it. And we're fortunate to have some state funding and United Way funding and private giving to help support this. But folks buy in and really appreciate the model. They see that it works, that we're able to collect the data we need to collect and serve people appropriately. And, when we're looking at double the national average of people entering and staying engaged in treatment, they see, the secret sauce of peers helping peers in this process works, right? And so
I can't imagine that anybody would think that it wouldn't work, because isolation is such a big, big issue. I think about myself. I live with bipolar disorder now. I was diagnosed back in 2003, and I never used a warm line because I didn't know that it existed. But I use support groups. Now, support groups are much, it sounds, and this is where I want you to sort of correct me if I'm wrong. One of the things, I felt very alone. I felt like I was the only person who lived with bipolar. I felt like I was the only person managing a mental illness. Nobody else around me understood, so I had nobody to talk to. Now, I did have the ability to get to a support group where I sat in a room with other peers, and suddenly we spoke the same language, right? We had some of the same concerns. And of course, and this was a big one too that you alluded to, Ben, the people there were like, no, Gabe, you need X. And X was a resource, or I didn't know any of this existed. I had just been diagnosed a few months ago. It sounds like the real big advantage of hiring peers is they have that commonality. They share that language. And this is the last thing I'll say, I promise. Could you imagine if you were a new parent and you were struggling as a new parent and you had no other parents to talk to, no other new parents to talk to, and then you called a number and the person who answered the phone had no children, but the best of intentions. I think when people hear that, they think, well, that doesn't sound right. Can you speak on that a little more? Because there still are some people that are like, well, now, wait a minute. You're getting advice from each other? Is that bad?
Yeah, no, it actually is a real good thing because, if you've gone a mile in that person's shoes already, you've already walked that walk and gotten the T-shirt, if you will. You do have a different set of experiences that makes you totally different and more appropriate to be able to assist that caller. The other thing is, for folks who don't have lived experience, it can come across as sort of judgmental to someone on the phone. And so the beauty of this is, with a person who's living that experience directly, it becomes a judgment-free zone because they have seen everything. There are not many client scenarios that come our way that are really new to us. And so they've experienced it themselves directly, or one of the other members of the call center team has experienced it. So then there can be the assistants reaching out to the call center worker that works next door to them in the office. So it easily works because we've got folks with different diagnoses in their backgrounds that are engaged in the call center. And so if a call center employee that has a depressive diagnosis is working with someone who's schizoaffective. Well, that's totally different from depression, but the good news is we have a staff person that does have that expertise with schizoaffective. And so then that person can be either the consultant, right, for the call center staff person, or can assist directly, and we can move that client to work with that particular individual if we need to. So there's lots of flexibility here, lots of cross training, and folks learn directly from doing the work. But we also, of course, do a lot of training as well.
I find myself always asking this question as a final up to peer support, but nobody is saying that peer support, the warm line, talking to people with lived experience, is the only tool in the toolbox for people trying to recover.
Right.
There's often always this kind of little tiny, oh, well, all the peers believe that they should ignore their doctors, their family members, their loved ones, and all of the information that's out there and only talk to each other. Can you talk on that for a moment? Because it's a misconception and a myth, and I'm not really sure where it came from, but it
Yeah.
persists.
Well, I think we have to be somewhat cautious in answering that question. And the reason being, one of the hallmarks of being a certified peer recovery specialist is you're not going to try to get in the way of any treatment decisions of the treatment team. But that said, a call center specialist, a certified peer recovery specialist, does have the ability to coach their caller up, right? And get to hear what's going on with that client, listen to them, restate what they have been told on the telephone to make sure they've got their scenario right. And then they have the ability to help reframe things. And sometimes that reframing things is through a very brief, limited self-disclosure opportunity with a client. So sometimes clients say, oh, you don't understand because I've got, bipolar disorder. Well, someone on our team is going to say, well, that's where you're wrong, because I do suffer from bipolar disorder. Right. And I've been, in recovery for how many years, or I do suffer from schizophrenia and I've been in recovery for so many years. So that's the sort of thing where they can help people with that limited self-disclosure. We're not going to butt into treatment decisions of, local hospital or doctor's office, but we are going to zero in on, well, let's focus on how do we support the treatment plan and help the client navigate any challenges that they've got, because there's tons of things that can pop up. Like, for example, they don't get along with their doctor or their therapist. Well, that's something that is a teachable moment. People on our team have been there. They've lived that one, right? So how do you navigate that? You seek another therapist, and then you try to move to that therapist. Hopefully they're in the same group. If they're not, then you move to another one. Or what if you need different medication? The meds you're on are not working. Again, teachable moment. How do you help them learn the self-advocacy skills so that they can have that conversation with their doc or their nurse practitioner? Our team has been through that, so they can help explain that. They're not going to question, whether Lexapro is the right thing for you or not, but they're going to say, sometimes some medications don't work for certain people, and it's worth a shot to have the conversation with the prescriber. If you're not responding in a certain time frame, then have that conversation. Yeah, and our people are knowledgeable enough to help people understand the basics of some things, like the antidepressants usually don't work right away, right? It takes a while to titrate up to get to the right level, and so you have to be patient through that process. If you don't like the side effects of certain meds, that's when you have to learn how to vocalize what's going on, so you can tell the doctor, hey, this is causing me all sorts of gastric distress. I can't tolerate. Well, the docs can't necessarily guess who that's going to happen to or not, because it doesn't happen to everybody. It happens to like 5% of the folks. So our team is going to help folks learn how to navigate their treatment plan with their treatment team to advocate for themselves what they need. And so they're knowledgeable. They're going to help people understand, if one med doesn't work, we might need to switch, we might need to add to it, that sort of thing. They're knowledgeable about different antipsychotics, so that if someone is taking oral meds for schizophrenia and they're not really working, well, then they can coach that person up to have the conversation about, well, these aren't working, but I hear there might be some other options for me. Can you help me understand those options, doc? Right? And then the doc can explain about injectables and stuff like that. But we're not getting in the way of treatment decisions.
What I like about everything that you just explained is that it took some time. It took you a few moments to explain that. And I think about, does a psychiatrist have time to explain these things to a patient? And the answer is almost always no.
That's
so
correct.
A lot of times patients, they believe that they're the only one. They believe that side effect is not the normal part of being on the medication, but rather something that is only happening to them. I laughed a little when you said the gastrointestinal distress. I was put on a new medication, and for the first week, this was a huge problem. I know I can already hear my mom saying TMI, but luckily I was warned of this, and they said this goes away after about 6 weeks, and then you get all of the benefits of the medication without the side effects. But I can only imagine if the only place that was written was on the pamphlet that they give you. And that pamphlet is that tiny type. And I say pamphlet, but it's actually just like 4 printed out sheets of tiny type that lists every possible thing. I wouldn't read it. I wouldn't recognize it. I would have this and I would be like, forget it, I'm off.
Right.
And that would be so sad, because I've been stable on this medication for literally years. It sounds like these are the kind of things that the Warm Line can help with, giving a patient the opportunity to talk something out that, unfortunately, for better for worse, we just don't have time to talk out with our doctors, especially because when we leave our doctor's offices, it's a maybe. We might have that side effect. That the doctor just cannot cover every possible side effect with you. There's no time.
Right. Well, here's a pro tip. So we know that going to the doctor nowadays has a very shorter window of time to actually communicate with the physician. So if you see a nurse beforehand, there's another opportunity to talk about some of the things you're experiencing. The meds aren't working, the meds are causing me gastro problems, that sort of thing. Make sure that nurse writes them down. Then you've got at least somebody writing it down by the time it gets to the doc. And then if you only have 7 minutes with the doc or 10 minutes with the doc, well, now the doctor at least is being handed that information directly before they come in to see that patient.
I cannot agree with that more. I'm a big firm believer of what's your top 3? What's your top 3? That way you can just walk right in and just read them right off. I know that we're nearing the end of our time together. I know that people like data. I like data. Do you have any information about call types, trends, results, outcomes? What are you seeing from the Warm Line program that we can sink our teeth into as far as outcomes, data, results, trends, and types?
Well, the intriguing thing was we didn't know exactly the types of calls or where they'd come from at first. So it's about 70% of calls are mental health related, about 20 to 25% are addiction related. And so that's interesting to note. The insurance breakdown is really pretty close to 30 to 35% Medicaid, 30% Medicare, and 30% commercial insurance. So it's pretty interesting split. And now that we are so aware of that, because we've been doing this since 2013, we're able to identify a lot of information based on that, their payer source. But 95% of all callers are calling directly for assistance for themselves. And, we do get friends and family, of course, who call, but mostly it's the individual who's struggling. And, Gabe, I'll tell you something about people when they pick up that phone to make that call. They have done the hardest thing they will ever do in their life, because they've acknowledged that, hey, I don't know what it is that's troubling me, but I need help. And so they've done the hardest thing, the bravest thing. And when folks do call us, they are scared. They don't know what they need. They don't know where to go. And they're afraid of what their family and friends are going to think about them for seeking help. And our team is really skilled at helping folks understand they're not alone, and help them through that first call so they no longer feel afraid. And from there, as I say, the magic happens. Beautiful stuff happens. They develop a phone a friend, lifeline, someone they can talk to, and the call center is open 6 days a week. Of course, Monday through Friday during the week, during usual business hours, Monday and Tuesday nights to about 8 o'clock, and on Saturday from 11 to, I think, 3 or 4.
Wonderful. Ben, sincerely, thank you. Thank you so much for being here. We're at the final thoughts. And I can't find, whenever you try to do anything, there we go. There it is. Ben, do you have any final thoughts for our audience before we leave? And of course, you can always learn more at namitn.org. You can email us, or of course, join the email list. But Ben, what are your final thoughts? What's the last bit of information that you want to share with our viewers?
Well, first of all, thank you for hosting this wonderful podcast. And I do appreciate it. And thank you to NAMI Tennessee and our colleague Jeff Layden for asking me. But I would just conclude that we all can work together to send one message every day. The illnesses are real, they're diagnosable, they're treatable, and treatment works if you go.
I love that. Ben, thank you so much. I want to put the Warm Line phone numbers up one more time. If you are in East Tennessee, the local number is 865-584-9125. Outside East Tennessee, we have a toll-free number for you. It is 877-642-3866. But obviously, if you have that local number option, or you're on a cell phone that doesn't charge long distance, hit up the 865 number so that Ben doesn't get a huge phone bill. Sound reasonable, Ben?
That's great. Thank you so much.
All right. Until next time, thank you everybody for tuning in to NAMI Tennessee at Home Live. Bye, everyone.